and hence the clinical manifestations and hence the change in biochemistry. I think unless we understand these sequences, just asking for what test should I do in a given patient with suspected Cushing and what kind of cutoff I should use is something which will never work in patients with Cushing syndrome. Why do I say that? I can tell you that perfectly normal test, whichever test you want to do, perfectly normal test can still represent a patient with Cushing syndrome, and perfectly abnormal test always need not represent a patient with Cushing syndrome. Even in a normal individual, in certain scenarios, you'll get absolutely abnormal tests, and that's where the whole clinical understanding comes to tell you, irrespective of that so-called magical numbers that you will derive from different test protocols, they are not sine qua non. That's what is a major message that I'd like to give you. So, sorry, just give me a second, please. Right. So when we talk about Cushing, we are talking about something which is autonomous and something which leads to persistently elevated cortisol secretion. The word is persistently elevated, which doesn't mean high levels of cortisol. It can be perfectly normal level of cortisol, but they are persistently elevated, and that makes the whole difference as we will see it along. It can happen because pituitary suddenly develops a tumor which is secreting ACTH, or it can happen because lungs develop this tumor which is secreting ACTH. Obviously, being tumors, these are autonomous and they don't listen to your needs of the body or the time of the day, because you and I know that when we travel abroad, for example, USA, we are kind of totally turned around in our day and night rhythm. And why is it that all of us feel groggy, sleepy, unslept, and want to just crawl back in bed? Because your cortisol rhythm has not set in, right? So cortisol rhythm sets together or synchronizes itself with day and night rhythm. If this is lost, I become Cushing. If I start having persistently elevated cortisol, that is something which brings in the problem of Cushing, even if the given level of cortisol is normal. Do we agree with this? Okay, so now every age group has very different pathological basis of producing autonomous cortisol secretion. In a small infant, unless proved otherwise, it's an adrenal unilateral tumor, and a little older child, like say 15, 10 plus, it is a pituitary tumor which is producing Cushing. Again, both of them are going to behave very differently, A, in clinical profile, and B, in your biochemistry as well. It is very, very, very important that you develop some sort of an experience in looking after these patients, because there's a huge overlap between normal and abnormal in terms of the test profiles, and I'll just like to give you some examples of that. Let's first begin to say, when do I consider in my practice a possibility of Cushing syndrome? So nobody will disagree with me that these are all patients with Cushing. You don't need me, and probably even you are not required. The mother is going to come to you to say, there's something wrong with my child. He's not healthy. There is the way he's looking all swollen up, and so on and so on. Plus, please consider, this is where the child began. Okay, now even if I tell you that this is where this child began and so on, please understand, this is where, how far back I could go on the photographs. Even this is abnormal. This is not normal. Okay, and I'll tell you why I mean that. When we cured this child, the way she shrank and the whole feature shrank was something else. So the amount of time that goes or lapses before you suspect and possibly come to medical attention is huge. And that is a problem with Cushing syndrome. because we're constantly looking for so-called striae of Cushing and so-called fractures and bone involvement with Cushing, which never happens in childhood, okay? It's a growth and growth which gets impaired, like it is in this set of twins. It is certain unusual manifestations which happen, like this pubic hair development way before other manifestations of puberty happen, and that's based on the pathological changes in your physiology. It's very unusual to develop striae. Do not ask for striae of Cushing, or do not use striae as your fulcrum to rule out Cushing. It is extraordinarily uncommon. And why is it uncommon? Children just don't get catabolic manifestations, period. Don't ask for it. They are in a state of anabolism at all times, and they don't get these kind of breakdown in skin to produce striae. So that is extraordinarily A, uncommon, and B, late. You don't want to make a diagnosis in a child so late in life, having gone through the period of cortisol excess for years together. That's not your objective. Then let me show you the example of how you can miss it. You know, it all sounds very good when somebody comes here and gives a talk, but look at the real life. The real life scenarios are very different. Now, this girl, where I put the arrow on top of her head, this is like she's 10 years old. The mom takes her to the doctor to say, you know what, she's looking plumpish. This is not how she used to be, and she's also looking darker to me. So nothing is thought about it by the treating doctor. Don't worry about it. She goes away. She comes peripubertal, 18 to 25, to say the menses are irregular. Typical presentation of polycystic ovarian syndrome. Typical. And that's how they all talk about it. Irregular menses, weight gain, plus minus hirsutism. Okay? But please understand, she is actually hypercortisolemic. She had zero signs other than this. And look at the period for which the whole diagnosis is missed. And this is the reality of life that I want you to respect and understand, to say the slow and stuttering course that the Cushing can adopt can be very different, and it can be catastrophically downgoing in some patients as well. Another patient, this gentleman is a medical doctor, okay, and he has given me his permission to use this case capsule. He was sitting in his clinic and suddenly felt so unwell. He just stopped the clinic, went inside the room and just rested. He was having blinding headache. He himself diagnosed himself to say he's got a pituitary adenoma, or there is some sort of something happening in his head. Went and did an MRI, figured out that there was a big pituitary adenoma with a bleed sitting over there. But look at his story. His story is that at 10 years of age, he had renal calculus disease. Nothing is thought about it. At 15 years to 25 years, this is the only picture I have, he goes through the whole medical curriculum and training, where every consultant keeps telling him, you know, your weight is no good, you need to lose weight. He measures his blood pressure, he's hypertensive. See, weight gain, hypertension. You're getting into complications of exogenous obesity. Look after yourself. He is Cushing. He is Cushing. And that doesn't get added. The 2 plus 2 just don't get joined. It's not so simple. It is very different in different patients, how fast or how rapidly they'll progress through different symptom complex, and that is a problem with Cushing. So the common symptoms and signs like weight gain is present in multiple other disorders and becomes a very poor discriminator for you. And what we look out for categorically, what we are tuned to thinking of so-called striae of Cushing, is extraordinarily uncommon. So problem is, there are no classic symptoms and signs beyond growth failure in pediatric age group, and that is a major challenge in suspecting the diagnosis of Cushing. If I suspect, and now I want to move to figure out biochemistry, but before I do that, sorry, anything on clinical presentation as a question, query, experience, comments, anything that anybody wants to share. This cannot be a monologue, please. Yeah, I'll repeat the question, please, before the mic comes on board. The question is, I kept on harping on the fact that it has to be growth failure and weight gain, growth failure being a very dominating sign. His question is, can I have minus growth failure as a symptom or as a possibility in a patient with Cushing's syndrome? Have I got your question right? Please understand, it all depends upon when do you capture your patient. If I capture my patient in few weeks, few months with symptom complex of Cushing, because of whatever be the reason, I will not have growth failure. It is all sort of how do they present and how do we sort of associate or think about the diagnosis. So growth failure need not be present. By and large, adrenal lesions, which are far sort of shorter in the symptom complex and duration, need not have growth failure. Okay? Any other questions? Yes, ma'am.
Yeah. I came across 2-3 patients who are obese and who are having normal for the stature, having the drug-induced Cushing. Obesity will give rise to repeated respiratory tract infection because of the low reserve.
Very true.
In village places, they used to treat by the steroid preparations. And these patients are with normal stature, having the Cushingioid faces and found to have this thing. This is a drug-induced Cushing.
So I think Preeti's point is extraordinarily well taken, and the cause in pediatric age group for Cushing is exogenous. Endogenous is very, very, very uncommon, and I think the numbers that I showed you is completely a referral bias. This is an extraordinarily uncommon disorder to deal with in childhood, and what it essentially means is that even if I suspect a patient with Cushing, it is absolutely pertinent that I first rule out exogenous, even if there is no history of any kind of drug intake, exposure, just don't worry about it. First thing that we do is rule out exogenous Cushing. That is a rule under which we address the test parameters in patients with Cushing's syndrome. Do we all agree with it? And I think, Preeti, I'm so grateful that you brought out this point. I think in this whole sort of meet the professor, it doesn't matter if you don't remember anything, forget it. Suspected Cushing, ask for a basal serum cortisol. If that is suppressed, only then you have got your diagnosis, but only if it is normal, don't rule out a patient with Cushing syndrome. Do we get this clear? Okay. Yes.
Ma'am, I have a similar patient of repeated respiratory difficulties, having steroid frequently, presented with an respiratory difficulty, so-called diagnosed acute exacerbation of asthma. She had got Cushingioid facies and also on biochemically hypokalemia. Hypokalemia.
That is endogenous. That exogenous.
Yeah. Then we just initially she had no hypertension, but after 10 days, and when we are doing biochemical, that is urinary cortisol and dexamethasone suppressions, all are normal. But within 10 days, she developed hypertension.
Two important points that he brought out. First thing, there is some sort of background of possibility of steroid intake, and that kind of, takes you away from endogenous state. It always brings up of exogenous intake as a most important aspect of the story. But this child has hypokalemia. No child who is just, getting into repeated respiratory tract infection has any business to disturb potassium. That is absolutely important, but more important than that was the other test parameters which were put together for Cushing are normal. patients with Cushing, and I haven't put together that case capsule, patient with Cushing syndrome can do this. They just do that. So today they are sort of very hypercortisolemic, they just come down tomorrow and then they can't start doing that. They can cycle in and cycle out of so-called endogenous state of Cushing syndrome. So it depends upon when do you capture them. If I capture them when they've cycled out completely, all my test parameters will be normal. But my driver to persist in that child will be presence of hypokalemia, even if I didn't have hypertension. I cannot accept hypokalemia in that child, right? So it is very important when do you investigate these children, okay? Say that again. I'm sorry, I didn't get you. His question is, why did I emphasize on renal calculus disease in that particular child? The medical doctor that I just showed you as a case capsule. Hypercalciuria is one of the pathological or pathophysiological change which happens in endogenous hypercortisolism, especially long-standing ones. So they can have renal calculi in maybe 10 to 15%. It's not such a big hero. It's not a presenting feature. All that I'm trying to say is that in that doctor, I don't know when did the disease start, but that was one of the pathology as one of the milestones that I had in history. I really don't know when did he start, but all that weight gain, all that hypertension was definitely part of endogenous hypercortisolism. Okay? Okay, I think I'm not doing very well with my time frames. It's just 5 minutes which are left. So A, feel free to ask questions, and B, I'm going to go through just few of the aspects of how do you prove a suspected case of endogenous hypercortisolism. Somebody said something? No. Okay. So you know what, see, if you have a patient like this, he is a doctor's son, okay? He just goes on the operating table for the simple surgery of ingrowing toenail. It's something so simple and nobody thought a big deal about it, okay? The nurse in the OT just decided to take his blood pressure, and the diastolic came to something like 9500, and then the whole story started. Cardiology reference, nephrology reference, and because nothing is being put together, now comes the endocrine referral. And I must tell you, endocrine referral is always last. If you don't find anything, endocrine cause for something. So that is very common, and in your life you'll learn that. Endocrine is always the last port of call to say, is there something endocrine that you can help us with? Fair enough. The referral was metabolic syndrome with hypertension, endocrine referral. But this is Cushing. Just take my word for it. This is Cushing. The point that I'm making is that if you have such a mild Cushing, where even the doctor, parents don't suspect there is something wrong with this child, and they think that child is healthy, good-looking child, that is a child where your test parameters will go wrong. Mild patients with Cushing may have normality of test parameters, and it becomes very important how do you select the number of tests which are available to you, how do you select them and interpret them, okay? Now, you have some sort of fair number of test options which are available, and ladies and gentlemen, you must think one thing before I go through all these tests. Why do you have so many tests? If the disease is something so pathological, why isn't there one single TSH to prove primary hypothyroidism like test here? That's because no test is perfect. TSH is such a perfect test. Whatever you tell me, this child has gained weight, he's lethargic, his school performance is going down. If my TSH is 3, I'm going to say he does not have primary hypothyroidism. It doesn't matter what you tell me. You give me 100 symptoms and I will say, no, he doesn't have primary hypothyroidism, and you all will agree with me. In Cushing, you do not have specific, sensitive test with good yield of accuracy. And that's why you have so many test parameters with which you need to work. And you need to use them. You need to fall back upon them. They're not just sort of there to know about, okay? And it's absolutely important that under different cadre, which are related to A, quantitative aspects, B, qualitative aspects, you pick up any two parameters with which you are comfortable, A in terms of logistics, B in terms of interpretation, and use them to prove a state of endogenous hypercortisolism. It's necessary to do that, okay? Because sometimes in one test parameter you can go wrong. Even a normal child can show you abnormal results, okay? Because if you miss this step of proving endogenous hypercortisolism and just jump to step number 3, which is imaging, you will get into major difficulties. And that is one rule which should not be broken in endocrinology, okay? Now, first tests are based on rhythm, and I've got 1 minute left. So the rhythm in cortisol axis, in daytime, we all have a good peak in the morning, and it starts sort of going down at night, and cortisol goes to sleep in night like this good little fellow. But in Cushing, your rhythm does something like this. And that is a basis of looking out for midnight cortisol levels. Midnight cortisol levels, okay? I think I should stop here because, just 1 second, I'll ask the organizers. I have 3 more minutes. Okay, I have 3 more minutes. You know what, let's use these 3 more minutes for questions. Shubhrata, I'll use the 3 minutes for Q&A. Okay. Okay, we'll do that. We'll do that. Thank you so much. So basically, then what we did was, then what was done in the literature was to modify this because it's little challenging to collect the blood sample at midnight. You can't walk into the lab and give your sample. That's wrong, completely wrong. You started working with salivary cortisol collected at late night. With the same principle, to say in a normal individual, it should be sort of almost undetectable, okay? So if it is beyond this number, it is a state of endogenous hypercortisolism. So look at this, even in obese fellows or normal individual, it hits a nadir in this manner. But if you take a Cushing, do you see the shaded area? That's normal. And in Cushing, it sort of just remains so high at 2300 hours, okay? So that is a basis of looking at diurnal rhythm-based test, whether it's a blood or saliva, and it gives you fairly good degree of yield, of accuracy. Got it? And even if I have to repeat it, because many times you have to repeat these tests, you know, repeating saliva is relatively easy than repeating a blood sample, obviously, right? Urinary free cortisol never, ever work with one sample, never. Look at this. This is day 1 UFC, and these are controlled, these are healthy people. Look at these 2 guys who have absolutely abnormal UFCs. Okay, look at day 2, again there is somebody with abnormal UFC, not necessarily the same person. Even on day 3, there is somebody who's beyond the so-called cutoff. But if you now put a mean together, then what you realize, the possibility of false positivity goes down. Okay, so urinary free cortisol, which is quantitating the endogenous hypercortisolism, has to be done on more than 1 or 2 occasions to produce a semblance. Because you know what happens, basically speaking, in these patients, they do that. Even in Cushing, they have small cycles, big cycles, or very big cycles. Okay, this is very well described. So it depends upon when do I catch that child and when do I capture these data. That will decide whether I'm going right or I'm going wrong. So you always fall back on more than 1 test parameters or the same test being done more than once or twice to generate a possible accuracy of the results. Do we get this? Of course, we all know this dex suppression as a test parameter, okay? We know this, that in normal individual, you and I will produce, I'll take 1 second more, 1 second more. You and I will produce cortisol level which is less than 1. All of us will do that. Believe me, okay? We've done it in more than 1,000 Indian people, and we know this is what happens in them. Now, look at this case capsule. Just stay with me for 2 more minutes. You know what happens? She comes with the same questions and problems. Symptoms don't help you. It's not easy to pick it up. This girl's overnight dex suppression, which should be less than 1, certainly not more than 1.8, is 5.3. Does she have Cushing? What do you all think? Problem? We are in a problem zone? Okay. This is what happened to her. She was on an oral contraceptive pill, and that changes your dexamethasone suppression value. There are fallacies of dex suppression, and that is what you should remember. Like in this girl, again, same question, rule out Cushing and an ODS which is very bizarre and abnormal. I am so scared for her, and look at her. She does not have Cushing. It is carbamazepine which is doing that. Okay, so test parameters are as good as how you interpret them. They are not gods. You have to read them and put a meaning to that number. Okay, I have to stop here. So, any questions, please? Yeah, Rajesh.
Do labs do salivary cortisol? That is first question. Second question,
Sorry?
do labs perform salivary cortisol?
Yeah.
Okay, which one? Metropolis does it?
No, we get it done from Hinduja because we just kind of went through some QC parameters. So we do it from Hinduja. And the best part of the story is that when you collect it at 11 p.m., that is not the time the lab is going to be open. The child can leave it at room temperature at home and bring it to you next day morning. That's very stable.
Okay, so midnight cortisol versus salivary cortisol, which is more
So midnight cortisol versus salivary cortisol, the principle of physiology is same. The change in diurnal rhythm and the loss of nadir at midnight, that is a principle under which you are working. The difference between the two is that false positive rate with midnight cortisol as a serum value is higher because of lot of logistic issue, and also logistically it is very challenging to collect somebody's sleeping blood sample at midnight, which means the child has to be indoor and sleeping, you know what I mean? But salivary cortisol is standardized to be awake and in awake state at home. So it makes life easier, especially when you want to repeat them. Okay.